Good afternoon. I think I'm probably speaking now to a group who are more focused in this area than the larger audience that has a fair number have already left. The focus of what I really wanted to try to address a bit today is moving from the individual to environmental policy solutions. And I do that in part because in the area of cancer prevention, much of the focus up to now has been on individual level behavior change. And we know repeatedly that while we might get people to change their behavior at the individual level, we surely cannot get them to sustain it if they continue to live in environments that provide no supports to maintain that behavior. So I'm going to briefly talk about what may be promising now. But I wanted to start at, as Wendy said, at a very macro level, because I think it's actually quite useful. This Lancet report from last winter about what is the trajectory of disease burden. I think it's very relevant to note that many of the disease burdens that have gone down relate to, much of them relate to infancy, but they relate to issues of control of infectious diseases, of solutions related to malnutrition, but many of the diseases that are going up, diabetes, HIV/AIDS, clearly some of these we still don't have control of some of the more complex infectious diseases, but a number of these, in fact, as we move forward to look at how the major risk factors have changed, is to note that a number of the risk factors that are going up are relating to changes in our lifestyle that are associated with increases in energy and sedentary behaviors. Most of the risk factors that have gone down, again, relate to improvements in malnutrition, improvements in water sanitation, and control of different types of infectious diseases. I think it's really important to note that as we look over this report in 2010, the risk factors were ranked by attributable burden of disease. 15 of the top 18 relate to diet, physical activity, and obesity. And if we look at the asterisk there, this is the United States. So the United States still has, like many other countries, but ranks high in terms of having this as a major force in contributing to disease burden. So all of these orange-red marks indicate that these are the factors that are contributing substantially to disease burden in 2010. And as our current projections are in terms of what's happening in the area of diet, physical activity, and weight, unless we make more rapid changes in these areas, this is only going to continue or get worse. There are really complex interactions between some of these factors. So one of the things that people, I think, in the shift in the last 20 years was we're really understanding what's happening in the area of physical inactivity. And this is from one of the large epi studies that NCI has, looking at years of life lost associated with physical activity across every BMI category. So irrespective of whether one is in a normal BMI category or a very obese BMI category, being physically inactive, which is reporting no activity, which a fair proportion of the U.S. public don't really do any activity, is associated with quite a marked increase in years of life lost. One of the areas where we've made progress in physical activity is that we can now objectively measure it, and we're doing that within the NHANES, and it gives us another metric by which we can really understand what's happening in the U.S. population. This has been brought up by a number of speakers, but one of the things that I think is important to recognize is that comorbid disease is very, very common among people with cancer, and we increasingly now have data that are indicating that comorbid diseases such as diabetes, in fact, do increase the risk of developing cancer. So this is just a study from the SEER Medicare data from a number of years ago, but this has been documented now in terms of a number of epi studies where they have better ability to actually relate these comorbid diseases to risk of developing certain types of cancers. One of the things that hasn't been mentioned today, it's really, I think, an area towards the future, but this is the whole issue of the microbiota and how it might be influencing risk. This is an intriguing paper that just came out this year where they actually have transplanted gut microbiota to mice, and that actually predicts if you transplant the biota from an obese twin, the mouse will become obese, and if you transplant the microbiota from a lean twin, the mouse will stay lean, even though they both had the same risk for becoming obese or lean in terms of the breed of mouse that's looked at. So this is really a fascinating story, and in fact, I was just at a meeting at NIH the last couple of days, end of last week, where they're demonstrating that effects of antibiotic use and whether an infant is born vaginally or by C-section in the first month of life predicts their risk of developing obesity as a child. So, you know, we have data, right, that very early period of life is intense in terms of its programming in tobacco. We now have this same data in terms of obesity, even though we know that behaviors later in life are also important. But I think this is really a critical area where we probably haven't explored this enough in terms of this early life exposure and its relevance for some risk for some cancers. So I wanted to talk about some of the forces that I think influence the potential for having policies that address cancer primary prevention. And frankly, at this point in time, with a few exceptions, much of our cancer primary prevention is really health primary prevention, is not just focused on cancer, but we have huge shifts in the population demographics, which of course then influences the populations coming in and what their risks are. We have tremendous changes in human behaviors of daily living because of the way, you know, with automation, with how food is available to us, with how we relate, how we move through our lives. That it's unprecedented, really, probably in the last 20 years, how those changes are happening. A very clearly complex interaction among risk factors and relevance of cancer to many chronic diseases. We just had a lot of discussion this morning about improved understanding of genetic data, but what we didn't have a discussion of is we have had a similar watershed in using geographic information systems to actually be able to measure the environments in which we're living, and using GPS, using our phones that we all carry and other things, we really can actually capture the experiences that people are having, and the marketers are using it very effectively to encourage people to stop by that store and in fact go in and take advantage of a sale. We can use the same thing in terms of behavior. One of the things that hasn't been discussed is that it's very clear that politics are local, and so there's an increasing need, I think, to actually have local level data, because that does inform local action and mobilizes the population to be concerned about a health issue. It's really critical that we have accurate and standardized measures, because that's the only way we can enhance comparison, not just within a research design, but also across different studies. And we've already talked quite a lot already about the potentially complex data on human health with environmental and contextual measures. And while much of the discussion of individualized approaches that was discussed in the morning focused on genetics, this same approach to individualized approaches is necessary for behavior change, because we know that people's potential to change behavior is very much based on whether the behavior change is made relevant to their life and their context. And it is, I think, very concerning that many of the increases in diseases we're currently seeing are being driven by excess energy balance, and we now have onset of chronic diseases, diabetes, liver cirrhosis, and other conditions in young children. We haven't seen this before, to my knowledge, except perhaps in very, very affluent populations in ancient times. We haven't seen this before. So here's a list of range of areas that could be addressed in terms of primary prevention, and this is a short list. It's not certainly not comprehensive. and include tobacco, diet, physical activity, weight control, infectious diseases, the area of microbiota. I'm not going to be talking about, but there is perhaps greater potential to begin to understand the role of environmental toxins and pollutants as we improve our measurement systems. I've mentioned this issue of comorbid diseases. And in terms of cancer screening and primary prevention, as Marcus indicated, we really have a ways to go where this is one screening technology that actually does lead to primary prevention, and we still have not yet enabled the population to get the benefit of that screening because not enough people are doing it. So as we think about key concerns in selecting priorities, one of the big issues is resolving disparities while improving overall population health. That really has to be an issue for where we think we should target. A big issue as we look at all of these factors are access and the ability to change people's exposure. Cost has been discussed, and then feasibility, though I would say that's sort of ever-changing and really changes as the times change, because something that may not be feasible today becomes feasible as political will changes and as people become convinced that it matters to change. So I just thought I'd briefly talk about a short list of things that are being considered. I don't think I was very good at going to 3 items, but the next slide I'll talk about more how I think the National Cancer Policy Forum might address some of these issues, so that I think I limited to fewer. But these are in part informed by a number of reports done by the Institute of Medicine and in the area of tobacco, issues on cessation, global control, and countering marketing. Nearly all of these efforts, particularly in health behaviors, are focusing on youth. In fact, I would say until we get down to the area of screening, we're probably focusing on youth. In the area of diet, we now actually have randomized controlled trial evidence that reduction of sugar-sweetened beverages leads to reduction in BMI, and we now have a host of cities and states that are experimenting in a variety of ways to make changes in diet and physical activity, including in the diet area, sugar-sweetened beverages, and are seeing some declines in children's rates of obesity. One of the big issues is access to healthy foods, such as grocery stores and food deserts, but one of the important areas there is not just to talk about providing people more of the healthy foods. We actually have to decrease unhealthy foods, and there was discussion about the use of behavioral economics to drive choice, and all of this really could have huge effects if we can implement this in USDA food programs, and these concerns of the SNAP program is a big one. In the area of physical activity, there's been a real focus around the area of walking and changing our built environment, transportation systems, and urban design to try to support that. Over the last 25 years, there's been a big shift in the area and understanding of research on weight control, moving from only treatment into obesity prevention, and that is huge, and we actually now have data that are really showing us that there are some areas that are of great promise in terms of obesity prevention. I think HPV vaccination was well addressed today, and of course, it is hard to believe that we're still not acknowledging that if we used a systems approach like school-based vaccination, we'd probably make more gains in that area. One of the things that's happening in the area of screening is the need to shift from just a crude age-based risk-based screening to something that's much more sophisticated. So how might the Cancer Policy Forum proceed? I think there is a lot of progress that could be made by having more communication between some of the IOM committees that have already addressed many of the things I put on the prior slide, and perhaps to have the National Cancer Policy Forum and pull a workshop to look at the key recommendations of many of these reports to say which ones do we think are most relevant to cancer control. We clearly need to enhance our capacity to monitor prevention efforts and outcomes, and there was just a really excellent IOM report on evaluating obesity prevention efforts. And I think in the area of research, we actually need much more research on improving adoption of recommended health behaviors in infancy and early childhood, given its critical effect on programming, but also given that in the area of cancer, we have not, I think, put enough focus on how those early exposures influence cancer risk for children as well as later in adult life. So why should we act now, even though we may not have full evidence about what will work? All these things are very complex, but this is what's happened. As we have in the United States said for years, we don't really know how to manage obesity, and so we're going to study it and observe it, but not actually act to reverse it. And so what's exciting is there have been a number of efforts in the last 3 years to actually counter these efforts, these trends in obesity. There's a national collaboration on childhood obesity research between USDA, Robert Wood Johnson Foundation, CDC, and NIH, and I think those efforts and others, we are seeing efforts, and much of the funding that went into the transformation grants by CDC and those other efforts to initiate programs to try to counter these trends, we're beginning to see some glimmers that it's made a difference. So I think there's really a lot of promise of where we could go.
Thank you very much.
Our next speaker is Dr. Catherine Alfano. She's Deputy Director of the Office of Cancer Survivorship, and she is going to be talking on the healthcare needs of cancer survivors.